Thank you. Thank you for having me today. I am really privileged to be able to share with you my personal experience and perspective. It's my personal experience and perspective. Just remember, it's not the gospel truth. It's my own experience in using the Optim.AI platform, and I have been quite delighted with it. It's something that I've been wanting to have for some time. And along the way in my presentation, I explained to you the reasons why I've been wanting to have something like that for quite some time. So these are some of my disclosures. Part of it, you see cayenne somewhere inside there, so take my words with a pinch of salt. Okay, ex vivo functional testing is something I felt passionate for, especially in AML. In AML, many of us know we give the patient chemotherapy, but chemotherapy is not like the solid tumor oncologist chemo, right? That's chicken feed. AML chemotherapy, your counts go really low before they start to recover, right? And some patients die because of that. In the past, we used to tell patients, induction chemotherapy, you have a 20% chance of dying from the chemotherapy. I mean, to us, we've kind of gotten used to it, but, 1 in 5 is quite a lot, I mean, in this room, 2 of us won't make it, right? So, or more, right? So, it's something that's quite distressing, and each time you put the patient through chemotherapy, he becomes less fit. If you want to take him to a transplant, you're going to salvage and salvage and salvage and salvage. By the time you bring him to transplant, he's no longer fit to go through a transplant, right? So, why put the patient through so much pain and suffering? And each time I feel the pain for them. So can we test the cells outside of the body? And functional testing is already something that is gaining traction around the world. I would say I really applaud Kayan for being a leader in this, for forging ahead. Yeah, because right now the world is starting to say, hey, maybe we should all be doing functional testing. But it's something that's kind of waking up right now. So, taking the cells out, testing them, you can do them in 2D spheroids. You can test it with ATP-based assays and lifestyle imaging, immunostaining, and others. Different ways you can test this. And then this is just one of the review papers to show, just to tell you that it's gaining traction. This discussion pertaining to functional precision oncology, and we can test them on 2D cultures, organoids, microfluidics, patient-derived xenografts. At the bottom, you see human patient. The truth is, when we don't do functional testing, we're actually testing on the patient. If I don't test your cells outside your body, I'm going to test on you. Yeah, so that's quite distressing. So you can look at cell viability and various other ways. So why not just treat all patients the same drugs? But we all know everyone's cancer cells are different. They have different mutations, different genomic background, different previous chemotherapy, and resistance patterns are different. So that's where some of our NGS testing, testing for FLT3, TP53, testing for all the different molecular markers, that's very, very important to do. But there may be other aspects that are invisible to us, other gene mutations, epigenetics, the responsiveness of the cancer cell due to mitochondrial differences and otherwise that we do not know. So I would say that you can see that responses also vary by tumor type and assay use. And this is my purpose is also to show that not all functional testing is the same, because I can't just take cells from my patient and test them in my own laboratory, because I will not have established the right assay, I would not have established the right parameters to do it myself. So it needs a fair bit of expertise and certain customization according to the tumor types as well. Now, so if you're going to taste a dish, right, you're going to take a dish, you're going to taste it first before you start to eat it, right? You're not going to just put the whole thing in your mouth and then, you have to throw up as a result. In the same way, I would say that when we give the patient chemotherapy, we can keep giving the patient chemotherapy on the left side, one round of chemotherapy, another round of chemotherapy, and as you keep giving the patient chemo, and experimenting on the patient, and like, you know, in a sense, the patient is the guinea pig in this sense. The patient can get progressively worse. If I have a patient with a disease that is going to be 90% responsive to the drugs I give, I wouldn't bother about functional testing. If it's 70% responsive to the drugs I give, I might not even bother with functional testing. But if it's less than 50%, let's say it's 30% chance of responding to the drugs I'm going to give, then I would consider it. For example, patient with a MDS background transforming to AML, I would do it. If a patient has relapsed before, I would do it because the chance of a response in that case is less than 50%. So there's a greater chance than not that your current chemo that you're going to propose to the patient might not work. So we should at least see if his cancer cells will respond. So I'm going to quickly share some cases. This is a patient with antecedent MDS AML, had some various genetic mutations, lenalidomide progression, FLAG-IDA, which is pretty good chemotherapy, no remission after that. Patient had functional testing. We looked at bortezomib, idarubicin, and venetoclax. Now, bortezomib, strange, it's a myeloma drug. Why should it be working in this setting, right? But bortezomib is also AKT inhibitor, so maybe that's useful in that sense. But also, importantly, we know bortezomib is this drug that gets rid of the garbage bin in your cells. Okay, gets rid of the proteasome inhibitor. So AML cells produce a lot of proteins. So when they have nowhere to dump these proteins, no more garbage bin to dump them, the AML might get compromised, some of the AML. So in this case, the combination turned out well on the Optim.AI, and patient actually responded to the combination. Had an allo transplant, went in complete remission. Unfortunately, after the transplant, had a relapse, and then by which time the drugs were no longer responsive. This is patient number 2. It's not an AML case, but I love this patient's response. Had CHOP, initial response progression, for the AITL, the T follicular helper group, azacitidine and romidepsin may cause some patients to respond, but there was no remission. Patient was CD30 positive. I gave brentuximab, gemcitabine, liver dysfunction as a result, but no remission. Did the Optim.AI, simple combination of romidepsin, venetoclax, and everolimus. And then patient had a near complete remission of the lesions. Had a transplant, and now about a year post-transplant, doing very well. Next patient is a little bit more complex. No, sorry, this is not the very complex one. So anyway, this is a patient with FLT3 positive. I gave, not keen on the transplant. She was about 70 years old. I gave AZA, VAN, and gilteritinib, and then could not afford any more gilteritinib, so remained on maintenance AZA for about 2 years, and then relapsed 2 years later. I gave her a dose of FLAG, but still had residual blast, so we sent for testing, and it was clofarabine, idarubicin, and sorafenib. I did not have clofarabine available at that time. We had a lead time of a few weeks. I had to decide whether I wanted to give sorafenib or gilteritinib. I think gilteritinib, I wasn't sure if the gilteritinib was already on the panel at that time or not, but because sorafenib is a close relative to gilteritinib, so I decided to give fludarabine instead of clofarabine, fludarabine, idarubicin, and then added gilteritinib. I saw venetoclax was fairly low there too, so I added venetoclax. Patient is currently in remission. This one is a patient, basically monosomal karyotype, TP53 mutated, failed azacitidine and venetoclax. Fairly old, I think 70 plus. The monosomal karyotype is where you have multiple monosomies. This group, without a transplant, is 0% survival. With a transplant, it's still maybe about 10 to 15% survival. So I was trying to persuade the patient to go for palliative in this particular case. So based on this, I felt that the margins were quite, I mean, it was fairly high, And also, all the chemotherapy was quite intensive. Clofazimine, fludarabine, and cytarabine, which a 70-plus-year-old in that clinical state probably could not tolerate. The patient agreed to it, actually. Next, patient with a initial diagnosis of CML with lymphoid blast crisis. She was given nilotinib. Am I losing this? It's still on, right? Was initially given nilotinib, vincristine, and prednisolone somewhere else, and then referred to me when the patient relapsed. We gave the patient hyper-CVAD chemotherapy, did not achieve remission. She actually became BCR-ABL negative, but JAK2 came up to about 50-60%. So we reassessed the marrow, we revised the diagnosis that this was a JAK2 myelofibrosis with acquired Philadelphia lymphoid blast crisis, which is very unusual, very, very strange diagnosis. So at that point, I gave flag-ruxolitinib, started venetoclax in view of the JAK2 and enlarging spleen. Now the JAK2 disappeared and BCR-ABL reappeared. And so I was bouncing between either JAK2 leukemia or BCR-ABL leukemia. I gave a flag-AZA and there was no response. Optim.AI recommended therapy. I saw selinexor, cyclophosphamide, romidepsin. Fairly young still, so I wanted to do what I could, but no response. I kind of knew it wouldn't respond, but we just give it anyway. Patient subsequently passed away. Patient 6, this is a patient who was about 68 years old, had a monosomy 7 on the karyotype, had aza-ven with the aim to bridge to transplant, salvage chemo with IA3+7. Based on the Optim.AI recommended therapy, etoposide, clofazimine, midostaurin was given. Blast actually reduced, and I actually had a window to put the patient to transplant, but had a lung infection. So, and still some persistent blast at the time, so the post-transplant was postponed indefinitely. Patient subsequently passed away. Patient 7, patient was on palliative AZA at that time, still wanted to pursue treatment, and based on the Optim.AI based therapy, I could use that to persuade the patient and family that I think I'm going to put the patient through more harm, giving him more and more chemotherapy, as opposed to going on the palliative route. Patient also had a TP53 mutation and quite poor prognosis AML. So if I look at some of my patients who had complete responses, some with partial responses, you can see that there's a certain particular pattern. In the deep blues, you tend to have very good responses. In the light blues, some responses. And when you have less of the light blues and more towards the reds, less response. But I mean, the colors, I think, Kayan, will change with time, right? But you can look at the NCVs, whether it's like 0.1 or 0.3 or above. And in the non-responses, in AML, and this does not apply to all tumors, in AML, I found that above 0.3 was my cutoff. The reason for this is, I think it's a little bit different for AML. AML is a very fast-growing disease. So unlike some solid tumors where you can give, and even though it's 0.4, 0.5, you can still get some patient, you can still have time to wait and the patient respond. But AML just grows back quickly. And if it grows back faster than your normal hematopoietic cells, you know, it's not going to work. So I think for AML, we need a higher cutoff. Actually, we need better drugs. You know, the drugs we have are not really that great. So finally, I mean, there's a little bit of a sharing session later, and a more interactive session. I want to say that on the left side, that's still very important. Looking at DNA mutations, epigenetics, and stuff like that. So you can pick up FLT3 mutations, you can pick up SF3B1, you can pick up various things, and this helps direct some therapies. On the right side, functional assays, like with Optim.AI. I think that's going to be something that is going to supplement our practice. But most importantly, in the middle is your own clinical judgment and experience. You have to judge according to how the patient is able to tolerate chemotherapy. You judge according to what drugs you have available. You have to judge according to what you think looks like a sensible combination, and considering all kinds of drug interactions and otherwise. So I think we're all learning in this regard, and hope to learn together as a community. And I would strongly advocate for us coming together as a kind of a functional precision medicine community within Asia Pacific. So when you speak to your patient, this is something I thought about for some time. We're going to ask the patient to do testing, right? You might think it makes sense, but to the patient, and part of you might not be so sure yourself, right? Because does it have a large randomized study? Maybe it doesn't have a large randomized study of patients on and off and that kind of thing. So say I tell the patient, your cancer is relapsed despite conventional treatment. It may not respond to the next round. There's this company that you have to do any declaration of conflict of interest, right? And they can do testing of your cancer cells against a whole panel of drugs. They will also test various combinations of drugs. It's not proven to be useful. Just because a drug is useful against your cells in a lab does not mean it will be useful in the body. What works outside the body does not mean it will work inside the body. And just because it does not work in the lab does not mean it will not work in your body. Okay? So qualify your although things do make sense, you have to qualify it. We don't have absolute proof yet. In the near future, probably we have suggestions, that this looks like the right path, and we'll gain more and more evidence. And I firmly believe that we will. Okay. Nevertheless, I think it's useful information, and it's another way of seeing whether these cells work outside of the lab first, rather than testing on you as a guinea pig. Right? The catch is the cost of the drug, which is whatever it costs you here. If you choose not to do this, we'll just follow the standard salvage chemotherapy protocols one after another to see which will work on you, which is perfectly accepted and standard practice. I think this counseling is important because, and also I found it liberating, because once I feel that I can counsel the patient this way, I feel liberated to suggest to my patient. So conclusions. Functional precision oncology is a field that is gaining traction with many studies ongoing. There may be a role to determine if the tumor cells respond to various combinations in the lab rather than subjecting patients to futile combinations one after another. Ex vivo does not always equal to patient response, but it kind of correlates. Choose your drugs and assess the pattern of ex vivo response. Counsel the patient with all the necessary caveats and document. And your clinical judgment acumen comes first and foremost. No one can speak better than you who are sitting right in front of the patient to advise the patient and who knows the patient best. So with that, thank you very much. Salamat.